Hi everyone, I'm Kathryn Sie, and I'm joined by my co-author and colleagues, Kiki. Kiki, when we first sat down to look at the case for children with both autism and epilepsy, what was the one thing that stood out to you as the biggest broken link?
It was the isolation, Kathryn. We saw that while neurology and behavioral health are both essential, they speak different languages. A parent is told to track seizures in one office and manage outbursts in another, but nobody is looking at how the seizure might cause the outburst.
Exactly. We call it the perfect storm in our introduction. The GABA system in the brain, which act like the brakes, is often faulty in both epilepsy and autism. We realize you can't treat one without the other.
Let's talk about the Family Resilience Hub. People looking at the flowchart on our poster might see a lot of boxes, but what does this actually look like at home in the living room?
It looked like a quarterback. In our model, the Doctor of Behavioral Health, or DBH, doesn't just wait for a crisis. They facilitate weekly 15 minutes huddle between the neurologist and the behavior team so that the care team is always in conversation with each other and the child's family.
And it's co-designed. That's a buzzword in healthcare, but for us, it means the parent is at the table for every decision. We aren't just giving them a care plan, we are building it with them so it actually works in their specific home environment.
One of the most technical part of our poster is the pharmacological review of levetiracetam, or Keppra. Kiki, why was it so important to include a deep dive into this specific drug?
Because Keppra is a pharmacological paradox. It's incredibly effective and easy to dose, which doctors love, but it carries a high risk of what people sometimes refer to as Keppra rage, side effects that include severe irritability and aggression.
Right. And in a silo system, a neurologist might see the aggressions and think it's just autism behavior, while the parents is terrified. Our pathways solve this with proactive monitoring. We use the integrated team to catch those behavioral side effects immediately so we can adjust the medical plan. It's safety through collaboration.
We have to be honest with our listeners. We've presented this beautiful model, but as we've discussed, this level of integration largely does not exist in the real world yet.
That's the hard truth. Families are falling off cliff when school supports end. Currently, the parent is the only bridge. Our proposal is a call to actions. We are arguing that integrated care should not be a luxury or a theory. It needs to be the clinical standard.
If we implement this, the projections are huge. We're talking about a 58% reduction in ER visits. That isn't just a number, that's thousands of hours of trauma avoided for these children.
And it's about the return on investment, both financial and human. When we support the family, we build resilience that lasts a lifetime.
So, if you're looking at our research, don't just see a clinical pathway. See a blueprint for a system that finally treats the whole child.
Thank you for joining us. Let's stop asking the family to bridge the gap we created. Let's build the hub together. I'm Kathryn Sie, and on behalf of Kiki and myself, thank you for listening and for caring about dual diagnosis. We leave you with this thought. A child diagnosis may be complex, but their care should not be a base. The most powerful medicine we can prescribe in a system that finally speaks with one voice.